Hello, everybody. My name is Dr. Al Hewer. I am a professor at Rutgers School of Health Professions. I'm an adjunct faculty at the County College of Morris in Northwestern New Jersey's Respiratory Therapy program. I also edit several textbooks, including Egan's Fundamentals of Respiratory Care. But I'm coming to you today for a very different reason. I co-own with Terry Shenfield A&T Lectures. Terry and I host an array of CEU events geared mainly towards respiratory therapists and nurses. We prepared a series on sleep medicine, if you will, and this particular lecture focuses on sleep medicine terminology, understanding the lingo. Now, some of the terminology I'll be going over in this presentation you will be familiar with, perhaps much of it. But we have a very varied audience. We have both folks that are very experienced in sleep medicine. We have folks that are not very experienced in sleep medicine, but they have a big interest in entering, if you will, that subdiscipline. This presentation will be most beneficial to both experienced individuals to review this terminology, but more particularly to the individuals that are trying to, again, increase their familiarity with sleep medicine. Again, this lecture will focus on the terminology. It will try to actually not just define terms, but put them in context. We hope that you learn a lot from this presentation. Terry and I want to thank you all for coming to us, and we hope you come back. Let's get started. So let's kick things off by focusing on the learning objectives that we'll examine during today's presentation. So after participating in this session, you should be able to identify physiological terminology involved with sleep medicine, compare and contrast the labeling of sleep diagnostics, distinguish among terminology related to therapies for sleep disorders, and provide additional resources for those of you wishing to learn more about sleep medicine, vocabulary, and terms. So looking at the physiologic terminology, more specifically looking at the normal stages of sleep. Sleep is composed of two general phases, one of them being non-rapid eye movement, or non-REM, and the other one being rapid eye movement, or REM. Now, non-REM sleep is made up of three subphases, if you will. Each phase represents a progressively deeper stage of sleep. In adults, during a normal 8-hour sleeping period, non-REM and REM stages cycle back and forth every about 60 to 90 minutes for a total of about 4 to 5 cycles. What does happen as the night goes on and the individual is in, let's say hour 5, hour 6, hour 7, the cycles do become more compressed and are much closer to 60 than 90 minutes. So if you're depriving yourself of 2 hours sleep, you're sleeping 6 instead of 8 hours, you're actually disproportionately robbing your body of, if you will, more cycles, because those cycles are so compressed at the end of the sleep period. So let's take a deeper dive into rapid eye movement sleep, or REM sleep. It's named for the presence of rapid fluttering or rolling of eyes and is characterized by the loss of muscle tone during this period of time. In general, it constitutes about a quarter, or 25%, of the total sleep period. This is also the time when dreaming occurs. Skeletal muscle semi-paralysis is also present, which also reduces, we say VE, it reduces minute ventilation. It may be associated with mild hypoxemia and mild hypercapnia, particularly in those individuals who have concomitant respiratory conditions such as COPD. May result in upper airway obstruction, and the physiologic effects of REM may be more profound in patients, as I alluded to earlier, with pre-existing pulmonary or cardiac disease. Now, I caution you not to take this depiction literally. So what I'm really trying to show you is not a circle that's kind of blown up, if you will, and each section is proportionate. That's not really the case, okay? But what I am trying to show you here is that when individuals have untreated or undertreated obstructive sleep apnea, is that this normal, if you will, cycle or circle is fragmented, okay? So you have, normally this should be, you go from REM to non-REM stage 1, non-REM stage 2, non-REM stage 3, 4, okay? But what happens is it just becomes interrupted. There's these periods of awakening in between cycles, and in extreme cases, some of the stages are not even achieved. So some of those deepest stages of sleeping are not achieved, and therefore the recovery, the physical and neurologic recovery that normally takes place in sleeping is incomplete. So because obstructive sleep apnea is so prevalent, and because the implications of untreated obstructive sleep apnea are very bad, contributing to things like cardiovascular disease, high blood pressure, stroke, worsening of psychosocial disorders such as anxiety and depression, etc. It's also important to look at screening tools to identify who has the conditions so that we can adequately try to treat them. One of the screening tools is known as the Epworth Sleepiness Scale, commonly used as a subjective test of sleepiness. It's also the Berlin Questionnaire. It's a validated survey to help, if you will, identify obstructive sleep apnea patients. And the Stop Bang. Stop Bang is another assessment tool used to help diagnose obstructive sleep apnea, mainly at the bedside. It's a quick, I don't want to say quick and dirty, but it's a quick tool that's been shown to be pretty effective in screening patients as well. Looking at each one of these tools individually, this slide is showing an excerpt from the Epworth Sleepiness Scale. And again, what the Epworth Sleepiness Scale is all about is asking an individual to rate their likelihood of dozing during a variety of settings, from 0, no chance of dozing, to 3, a very high chance of dozing. Sitting watching TV, sitting, inactive in a public place, as a passenger in a car, lying down. So it doesn't mean that, if you're riding as a passenger in a car and you feel sleepy, it doesn't mean that you have full-blown obstructive sleep apnea. What they're saying here, though, is if in a lot of different situations, okay, such as this, if you have a high chance of falling asleep, then there's a reasonably high chance. Additional screening would be appropriate. There's a reasonably or increasingly high chance that you may have some sort of a sleep disorder. So they do allow for a range of 0 to 10, kind of normal range, identifying that many of us might, if you're going on a long trip and you're in a car, you might actually fall asleep and it may just be deemed normal. But if your score is above 10 to 12, that's not normal. And particularly if it's approaching that 20 to 24 range, it's a strong indicator that additional testing should be ordered. The Berlin Questionnaire is yet another more objective tool. So about a third, a little more than a third of the questionnaire is really dedicated to snoring, and it really talks about the individual's self, if you will, professing that they snore, their bed partner saying that they snore, etc. And it seeks to quantify not just snoring, but it quantifies other things as well, such as, are you tired and fatigued during the week? And it combines that to come up with actually a score. And then, 2 or more positive categories indicates that the individual is at a higher risk for obstructive sleep apnea. It's not conclusive, but it's validated, and we know that this would be a strong index of suspicion, again, if there's 2 or more positive categories. The Stop Bang questionnaire really was intended to enable clinicians at the bedside to, again, do some initial screening. And the Stop Bang all stands for something. The S in stop snore, the T is are you tired, the O is observed, anyone stop breathing, and the P is looking at blood pressure. Bang is, the B in bang is body mass index if it's greater than 35. The A is age. The N is neck circumference greater than 40 centimeters. And the G is gender, knowing that over 2/3 of the individuals that are afflicted with clinically significant obstructive sleep apnea are males. Another, again, stop bang being another way of initially screening patients so that they, if there's a high risk, that they eventually receive the appropriate testing through a polysomnogram to either confirm or refute the presence of obstructive sleep apnea or other related sleep disorders. Now, some of you may be familiar with the Mallampati score if, for instance, the hospital you work at or have worked at in the past, where respiratory therapists do, they intubate. So you may, in an elective intubation, ask the patient to open up their mouth and stick out their tongue and try to assess them for a Mallampati, or you may retrospectively, after either assisting with the intubation or doing the intubation, you may actually, rate the Mallampati score. At the hospital that I still work at clinically, we do intubate, and we actually have both, a electronic health record, a form that needs to be filled out, and a hard copy form. And the hard copy form actually asks the intubator to rank, if you will, the Mallampati score. I will tell you this, that my wife is in the next room, quite honestly, as I record this lecture, but she had surgery fairly recently, and the anesthesiologist who assessed her basically came to the bedside before the surgery, asked her to open her mouth up and stick out her tongue, and the anesthesiologist's response was, you have a big mouth. And I, of course, being a good husband, said nothing, because I would never want to accuse my wife of having a big mouth. She really does not. But in any event, he was trying to assess, again, her initial airway. But in addition to, using a Mallampati for difficulty or lack thereof for intubating, it's also one of the screening tools that can be used, with the understanding that individuals that have more tissue, if you will, in the oral pharynx and have a bigger tongue, there's greater difficulty in actually visualizing, the uvula, and you're not going to, directly see the glottis per se. But folks that have a higher Mallampati, a 3 or 4, would tend to have a higher rate of obstructive sleep apnea. Again, not conclusive, but another one of the evaluating screening tools that's in our arsenal. With all of that said, the gold standard in, if you will, diagnostic tools for obstructive sleep apnea remains the polysomnogram, also known as a sleep study. It's a recording of the diagnostic variables associated with patient sleep, and these variables are simultaneously measured, and they include eye movements, airflow measured by a thermistor put under the nose, respiratory movements, so again, diaphragmatic and chest excursion, leg movements, EEG, so that's really brain activity, pulse oximetry, and ECG or EKG, which of course would be your heart rate and rhythm. A split study, per se, another term, if half of the study is diagnostic, so the pneumocardiogram, the sleep study, and the second involves, if you will, PAP or CPAP, airway pressure titration, to identify the appropriate pressures needed to overcome the obstruction. Now today, and I'll talk more in this presentation about auto-titrating. So a lot of the auto-titrating technology that we have there really renders the split study, I don't want to say obsolete, but less critical, because we now have these auto-titrating CPAP machines that they'll alter the pressure level, really flow, but it's ultimately pressure that's needed to overcome the obstruction. It can change based on sleeping position, the individual loses weight, if the individual has or has not been drinking alcohol, diet, things along those lines. So the auto-titrating not only will just auto-titrate to find that level in general, but will also auto-titrate on the same patient depending upon changing conditions. The AHI, or Apnea Hypopnea Index or score, is the number of apneas and hypopneas. Okay, think of hypopneas as the patient really they're breathing, but they're really not breathing in a substantial amount of tidal volume during each hour. So again, hypopnea, when a patient takes a shallow breath for 10 seconds or longer while asleep, airflow is at least 30% lower than normal. And they recognize that if it's, if it's less than 5, it's in that more minimal slash closer to normal range. And then quantifying mild from 5 to 15, moderates from 16 to 30, and then if you're north of 30, it would tend to be regarded as severe. So again, apnea, hypopnea index ranging from 0 to 30, but again, in that, if it's greater than 30, it's deemed to be much more severe. So some additional terminology, talk about sleep-related breathing disorders. So that's also a term. It's really not a single disorder, but it is the combination of several disorders, including obstructive sleep apnea, which, depending upon which book you look at, is a cessation of airflow for more than 10 to 15 seconds due to complete anatomic airway obstruction or closure. Hypopnea, when a patient again takes shallower breaths, as I alluded to earlier, and central sleep apnea is not there are no efforts. So with obstructive sleep apnea, there are respiratory efforts. Central sleep apnea, there's some issue with the signal being generated by the pons and medulla oblongata, or that signal being transmitted down, to the diaphragm in order to enable the beginning of the inhalation or breathing cycle. This is a graphical depiction of obstructive sleep apnea. And the most significant, distinction, because the next slide I'll show you central sleep apnea. If you look at the bottom tracing here, it's effort, okay? And what you notice is that there is continued effort throughout the period of cessation of breathing. In fact, that effort becomes more pronounced just before the patient resumes breathing, just before that airflow starts, and again the patient is actually breathing. Whereas in the next slide, you'll see a clear distinction. Bear with me. In this slide, the top two tracings look fairly similar to what we saw with the preceding slide for obstructive sleep apnea. The big difference is this. When you look at effort, or that bottom tracing, you don't see any. So you see the cessation of airflow consistent with a lack of effort. Unlike obstructive sleep apnea, the effort was there, but the airway, if you will, was closed. There was closure of that airway. So with central sleep apnea, again, there's some issue. It's called central sleep apnea. Really think of central nervous system. It's really, I'm kind of substituting that in there. But central sleep apnea is not due to, again, a physical closure, the tongue falling back and closing off that airway, whatever. It is, there is no, if you will, attempts to breathe, okay, until obviously that signal resumes and, the breathing cycle starts, the signal gets down to the diaphragm via phrenic nerve, diaphragm drops, breathing cycle, commences, etc. Now let's look at the term complex sleep apnea. So that's the actual term we're looking at. It combines aspects of obstructive sleep apnea and central sleep apnea. So it's a mixed. By the way, you sometimes see this with young children and babies, where you have kind of a combined, phenomenon going on. Without a pneumocardiogram, but without a sleep study, mixed sleep apnea is virtually impossible to detect. To actually detect that it's actually mixed, that it's not one or the other. Often the PCG or the sleep study shows central sleep apnea first, followed by obstructive sleep apnea. Once CPAP pressures are adequate to prevent the OSA, the central sleep apnea can be addressed. So you actually diagnosing it and addressing it in a step-by-step or stepwise fashion. Another term that you'll see is hypoventilation syndrome. Hypoventilation syndrome. There are multiple forms of hypoventilation syndrome or syndromes. The most notable is obesity hypoventilation syndrome. So in some of the older respiratory textbooks, they actually will label the patient a Pickwickian, out of, again, the early literature talked about, a Pickwickian, obese, as a character in early literature. And again, is seen in patients who have a body mass indices greater than 30. Some of the books say 35, so greater than 30 to 35. They tend to have elevated PaCO2s during wakefulness, greater than 45 torr or 45 millimeters of mercury. To make the diagnosis, daytime hypercapnia must be present. So what you'll find if you were to actually do a blood gas in these patients is not only is their PCO2 maybe 50, upper 40s to in the 50s, but their pH is probably normal, but on the acidotic side of normal. So 7.36, something along those lines. But not surprisingly, you'll see their bicarbs are elevated above that 22 to 26 level to buffer that constantly high PCO2. So their bicarbs may be like 32, something along 33, 34, almost what you might actually see with a chronic, COPD, CO2 retainer. Still other sleep disorder terminology, you have what's called circadian rhythm disorders. So your circadian rhythm is the rhythm of your, sleeping, for most of us, not shift workers, but for most of us sleeping when it's dark out. So going to bed at 10 or 11 o'clock at night and waking up at 6 or 7 o'clock in the morning, give or take. But we have individuals whose circadian rhythms are out of whack, if you will. They're not normal. Results from disruption of the normal 24-hour sleep-wake cycles and include things like jet lag, shift worker disorders. I know that I worked night shift for about a year, almost a year and a half, and I never really quite got accustomed to it. The biggest thing for me, a lot of it was big, but one of the biggest things was that I worked 3 12-hour shifts from 7P to 7A, and it was when I was not working that I had difficulty in kind of getting back in the groove of the rest of the world. My 2 brothers, a lot of my friends, etc., who were on a regular, again, sleep when it's dark out, awake when it's light out schedule. So it was very, very difficult, and for me it was, and for a lot of people it is. And they find actually the worst isn't just people that work a constant evening or night shift. It's sometimes firemen, police officers, military, where it's actually a rotating shift. That can have the greatest injurious effect on your circadian rhythm and contribute to circadian rhythm disorders. Then you have parasomnias, so undesirable physical events or experiences that occur during sleep, such as night terrors and sleepwalking. Both of them are very real phenomena. And sleepwalking, as you can imagine, can be particularly troubling because when the person is actually sleepwalking, they could fall downstairs, they could trip over something, etc. So it can be very, very problematic, mistaken for an intruder. Just again, a lot of badness can happen as a result. Insomnia, so persistent difficulty with sleep initiation. Again, the duration can be affected, the consolidation or quality of sleep despite the adequate opportunity. So they go to bed at 10, their alarm is set for 6 or 6:30 in the morning, but they can't fall asleep. And they sleep very little over the course of the night. Hypersomnolence disorders. So again, relate to patients that have symptoms of excessive sleepiness, including narcolepsy. But it can be, I don't want to say simple. None of this is simple, but hypersomnolence is one of the most common and the longest understood results of untreated obstructive sleep apnea. You get individuals who are getting in, they're falling asleep at the wheel, but it's 10 o'clock in the morning. And let's say they're a truck driver, or they're, a taxi, Uber driver, taxi driver, whatever, operating, on a big plant, driving a truck or a forklift, that sort of thing, and they're falling asleep at a time that you really wouldn't expect somebody to. So, when I did home care to individuals who we were setting up on CPAP or BiPAP, that was the initial thing. They got in a car accident, and it was like a car accident was they hit the accelerator instead of the brake, and it was 10 o'clock in the morning. There was no alcohol involved, no illicit drugs involved. They did tested negative for any of that stuff. There was no issues of diabetes, so they weren't in a diabetic ketoacidosis, and they did it more by the process of elimination to determine that these individuals or hypersomnolent. And there's been accidents on trains and things along those lines that have been attributed to this as well. And some of this has actually resulted in, Teamsters truck drivers are routinely tested for obstructive sleep apnea. Some of the other individuals that operate, train operators and things along those lines, heavy equipment operators are sometimes tested as a matter of course as well, just for that reason. This is an area that I've done a lot of work in, and I have a separate presentation on, and that is the consequences of or undertreated obstructive sleep apnea. And I've alluded to them in this presentation and other presentations, but the daytime somnolence, again, chronic sleepiness during the day, decreased administrative function, another term, so diminished ability to organize professional and personal responsibilities, and that could be like, you're off on a Saturday and you're going to go to watch your kid's soccer game, but you're also going to go to the bank, and then you're going to go dry cleaners, and you're going to go to the food store. But instead of lining up a map, if you will, that is logical and sequential, you're running from one end of town to the other end of town to this other town. You're like a ping pong ball, or a pinball machine, a metal ball and a pinball machine. You're just bouncing around instead of attacking things in a logical manner. Attention deficit, so untreated or undertreated OSA has a sizable effect on the ability to sustain attention over time. So something that I mentioned as far as hitting the gas pedal versus the brake. So less impact. So under or untreated obstructive sleep apnea has less impact on the reaction time and more on the actual quality of the performance. So again, you hit the pedal in about the same amount of time, but the pedal wasn't the brake, it was the accelerator, and you then end up going through a storefront and messed up the store, messed up your car, injured yourself, and hopefully nobody else, but can result in can be very problematic. And these are the sorts of things that you see sometimes in the news, that actually talk about individuals who were not under the influence. They eliminated everything else. It's like, wait a minute, something's off here. Building on the theme of the prior slide, so more on consequences of untreated OSA. Again, refractory diabetes, so elevated blood glucose not readily responsive to insulin, so insulin resistant. So individuals may have had no diabetes, or their diabetes was well controlled, but now their obstructive sleep apnea has gotten totally out of control, and now they now need a pump. Or they're testing more frequently, and they're finding that their levels are, more out of whack, and it may actually be related. You treat the underlying problem of OSA, and they get back into control. Hypertension, so high blood pressure, defined in this case as 129, greater than 129 over 90, can lead to a stroke or contribute to a myocardial infarction. By the way, what they attribute to hypertension, they attribute actually several, but the hypertension in particular to with each awakening. So someone they stop breathing, and then they're woken up, they resume breathing. There's stress hormones that are released, the fight or flight stress hormones. They attribute a lot of the hypertension, a lot of the refractory diabetes and the other issues to the stress hormones. You think about stress hormones causing vasoconstriction, and then eventually it happens so often that the vessels just stay constricted. They just become remodeled. They just learn how to behave differently, and they stay that way, all the time until the condition is treated. And the psychosocial dysfunction, worsening of anxiety and depression, and then overall reduced quality of life. So there's these questionnaires similar to what Elizabeth Juniper produced she created an instrument to measure quality of life in asthmatics. It's been translated into 50-something different languages, maybe even more than that now, but they have a similar instrument overall for just evaluating quality of life. And we know that individuals that have or undertreated obstructive sleep apnea, they have worse quality of life using these same validated instruments. Now, up to this point, a lot of this presentation has been like on the negative side of the equation. Like, oh my God, there's all of this stuff that can happen to you. And it's called all different terms for all these things that can happen to you. And I want to now kind of turn a little bit and really look at, some of the terminology that's related to the treatment side of the equation. Okay, the treatment side of the equation. So the mainstay for treating obstructive sleep apnea remains positive airway pressure, whether it's BiPAP, 2 levels, auto titrating, or CPAP, and determined via a pressure titration. Even the pressure, the auto titrating, still some basic parameters are still put in there that do relate to what's been tested during the actual sleep study. Other treatments, addressing the risk factors that individuals are excessively overweight, weight loss, avoiding alcohol, smoking cessation. Dental appliance for individuals who have particular abnormalities. So the dental appliance and the surgery are really aimed at individuals who've been screened, and it looks like the main cause is things like a large tongue. So macroglossia. Or microganglia, which would be a small mandible or small jaw, where certain surgeries can be done to advance the mandible, to reduce things like the uvula, so the UPPP surgery, or use a dental appliance to non-surgically advance the jaw into a position that's more conducive to airflow and less connected to contributing to obstructive sleep apnea. So let's drill down a little more on the terminology that's associated with positive pressure therapy. So CPAP, continuous positive airway pressure. I don't mean to condescend anybody, but for the sake of completeness, it's that one pressure that would actually be set, at 10, 12, 14, 8, whatever the case may be. BiPAP, the administration of positive pressure 2 levels, one of them being the IPAP or the inspiratory pressure, and the other being the EPAP, which would be the lower pressure, the expiratory pressure. Then we have AVAPs, which is becoming pretty increasingly popular and is available on more and more of the latest generation positive pressure airway machines. It's average volume assured pressure support. So you have a fixed EPAP or baseline pressure with an auto titrating IPAP to achieve a targeted tidal volume and or minute ventilation. So it has a kind of a complex algorithm that looks at the parameters that you set, looks at patient, but also looking at achieving or delivering the IPAP necessary to keep that airway splinted open to again get the delivered and return tidal volume and minute ventilation that's been put into the machine. And the last term I have in this slide at least is auto titrating. I've referred to this previously. It's a very descriptive term. It's non-invasive. The actual pressure, really flow. You think about it. It's a CPAP or BiPAP machine. It's really flow in a somewhat fixed capacity, your lungs and your airway, to achieve set volumes. And what the auto titrating does is it titrates the flow to achieve the pressures necessary to overcome the obstruction, and really the lowest pressure or pressures to overcome the obstruction. Analyzing kind of breath to breath, averaging them, and again delivering. Ultimately, it's pressure, but it's achieved by again a flow in order to overcome that obstruction. A newer modality, which I say newer. Strollo published the first piece in the New England Journal of Medicine in 2014. So that's, getting close to 10 years now. But it was a big deal. That was really the key. It was a very, very big deal in Strollo's initial study. It was 126 patients. It was not a controlled study, so there wasn't ones that got the therapy versus ones that didn't. What they did is they actually implanted this generator that had a sensing lead down to the diaphragm area, and it had a stimulation lead. And when it sensed that the diaphragm was dropping, it sent if you will, an electric stimulus to the upper airway, if you will, causing those muscles to contract rather than to relax, to contract and open up that airway. So it was implantable nerve stimulator used to treat moderate to severe obstructive sleep apnea. The 126 individuals that participated in the initial study all were very symptomatic and could not tolerate CPAP or BiPAP. So they had all these comorbidities, and they were in a bad spot. they gave this a try. These patients were monitored very, very carefully, and both objective, their apnea, hypopnea numbers dropped way down, and their rating of their quality of life went up immensely. And since Strollo's initial study, there have been several others that have supported his results and have supported that individuals that are compliant with the upper airway stimulator, that the benefit is sustained over years. Okay, and then in the bottom portion of the slide, I actually have two depictions, just separate depictions, showing you, yeah, indeed the generator is implanted under the skin, much in the same way that a pacemaker would be, but it operates very, very differently. And it, again, one sensing lead going down to the diaphragm area, and another one that's actually, sending the signal to the upper airway for those muscles to contract. Another term, but it's a term that's associated with a newer technology, is the night balance Lunoa by Philips. And the whole premise of it, rather than read the slide, the whole premise of it is to have the patient assume and stay in the appropriate position that's most conducive to overcoming an airway obstruction. Okay, so as Philips bills it, it's a mask-free treatment that helps you, the patient, stay in a side sleeping position to reduce breathing disturbance. What we know is that individuals sleeping in a lateral, side sleeping, decubitus with their head position, with their head slightly elevated, okay, that's a position. If you took 1,000 patients that have obstructive sleep apnea, that many of them would have less, the problem that wouldn't necessarily go away, but their AHI scores would improve just by side sleeping. And you combine that with things like weight loss, smoking cessation, stopping alcohol consumption or reducing alcohol consumption would all add to it as well. This particular night balance by Lunoa, the term, but also it's what it's officially called by Philips, is all about the positioning, and it will send a signal, a gentle vibratory signal when the individual again resumes, let's say, a back sleeping position, which is more commonly associated with OSA and snoring and things along those lines. It's been found to be non-inferior, that's the term that's used in the research, to PAP therapy. Okay, it is a palm-size, compact, discrete device worn comfortably across the chest, soft, adjustable. I know it sounds like a feel-good thing by Philips. During your sleep, develops auto-customized gentle vibrations that prompt the individual to move off their back into a position that's more conducive to the airway being open, and the obstructive sleep apnea being minimized or eliminated. Now let's take a look at different forms of surgical interventions that can be helpful in reducing the impact of obstructive sleep apnea or curing it outright. The first of them is a procedure that probably many of you in the audience have had, and that's called a tonsillectomy. So our tonsils and our adenoids tissue on the sides of the oral pharynx. Again, many of us had them removed when we were children, but there's individuals that perhaps have not. And in addition, if the individual has, a diagnosis of, sleep disordered breathing or out and out obstructive sleep apnea, they may well experience some relief by having a tonsillectomy. And like a lot of these procedures that are done on soft tissue in the mouth, done typically with a laser scalpel, unfortunately, it can be much more painful for adults than it is for children. It just has to do with the maturity of the tissue, things along those lines. So it tends to be, in adulthood, we have to have more tissue removed. It's a little bit more radical, etc. So again, that's the main reason why most individuals have had a tonsillectomy when they were a child. The other rationale for doing it as a child is if a child has had repeated infections, and they find that individuals who still have their tonsils and adenoids, they tend to be more prone to developing, throat infections. So many of us have had them removed. We shouldn't take that for granted because there's individuals that have not. And again, assessing the patient to see if those adenoids and those tonsils are exceptionally large and they have a concomitant diagnosis of obstructive sleep apnea or sleep disordered breathing, they may experience some relief from having this surgery. building on the theme of surgery, there's another form of surgery in addition to a tonsillectomy that is called the UPPP or the UP3. It's also referred to as a uvulectomy. Now, when we were kids, when we opened up our mouths, that we used to call it our punching bag, the piece of tissue that's actually hanging down, not entirely, but partially down near the back of your mouth. That's known as the uvula. And the uvula, and particularly the tissue around it, okay, when it becomes, whether it's swollen or it's just naturally enlarged, particularly during periods of deep sleep, that tissue can collapse backward and either form a partial or an entire occlusion of the airway. Again, feeding into the term obstructive sleep apnea. And that therefore, for individuals who are previously screened and determined to have an enlarged uvula and tissue around it, they may well be candidates for a UPPP. It's not the sort of procedure that's done, oh, someone has obstructive sleep apnea, they don't tolerate positive airway pressure, so therefore we're going to do this procedure. But in the process of actually screening and assessing them, and perhaps they've actually failed positive pressure therapy, and they have some concomitant, if you will, comorbidities, the hypertension, the refractory diabetes, et cetera, it would be those individuals that could potentially be a candidate for the UPPP. Surgery is typically done with a laser scalpel. It is often done today actually as on an outpatient basis. That tissue is particularly well innervated, so it can be, particularly painful for a number of days after the surgery. For those people who are properly pre-screened, whereas they determine that this particular tissue is larger than normal, maybe impeding the airway, and the individual, therefore has the diagnosis of, some sort of a sleep disorder or outright obstructive sleep apnea, they may be, candidates. Most commonly, as this slide indicates, that it's most effective for individuals that have mild to moderate cases of obstructive sleep apnea. Also along the lines of surgical interventions would be maxillomandibular advancement. So let's say the patient is pre-screened, so they're determined to have obstructive sleep apnea, and furthermore, they're pre-screened to have, if you will, a recessed and or narrow jaw. What they can do, it is tough surgery, so they actually have to go in and they will break the jaw surgically, cut it or break it, okay? They actually put a prosthetic device in there to advance it and hold it in place until it heals. But you can imagine individuals that, it's traumatic, absolutely traumatic. So it really would be for individuals who fail, that, they not only have a significant obstructive sleep apnea diagnosis, but also they have the comorbidities that are affecting not just their quality of life, but they're developing, dysrhythmias, high blood pressure, they're at risk for stroke and MI and things along those lines. And for various reasons, they may not tolerate the positive airway pressure, they may not tolerate the upper airway stimulation, etc. And it would only be those candidates for this that would be deemed appropriate for this form of surgery, because it's so darn drastic. But again, it is something that is within our arsenal in treating these patients, and I would be remiss if I didn't actually include it in this discussion of terminology and treatments. So some other treatment modalities that are out there are tongue reduction surgery for individuals who have what's called macroglossia, so they have a large tongue, and there are ways that it can surgically be reduced in size. The problem is that the tongue is very well vascularized, it's very well innervated, it has taste buds in it, etc. So great care. I mean, it's a very specialized surgery, and it has to be reserved for a very small percentage of individuals that have obstructive sleep apnea, that are deemed, again, they have clinically significant obstructive sleep apnea. They have the concomitant severe comorbidities, the things I mentioned, high blood pressure, etc. And they have not responded well to other surgeries. Because again, there may be this lasting loss of taste sensation and other issues along those lines. And I would say last but not least, I remember that I gave a presentation years ago on tracheostomy and talking about the indications for tracheostomy. And indeed, a tracheostomy would be perhaps one of the more extreme, not perhaps, is one of the more extreme surgical interventions for obstructive sleep apnea. Because keep in mind, it would probably not be, it would be a long-term tracheostomy. It's not one to facilitate weaning from mechanical ventilation and then downsizing and then hopefully decannulation, etc. This patient would probably not be a candidate for any short-term removal of the tracheostomy. And it would also be for those patients that they failed everything else and they have all this concomitant issues. And I remember I was presenting and I said that it is a treatment for obstructive sleep apnea. There was somebody in the group who was actually very big on non-invasive therapies for ventilator-dependent patients, and he took exception to it. And I said, listen, I'm presenting to you the arsenal, okay, of treatments that are out there. I'm not saying that I want to trach anybody for obstructive sleep apnea, but just understand that for patients who have all these concomitant conditions, that it is an option. It may not be a great option, but again, typically a last resort, and not amazingly, but it's highly effective. Okay, so when you really think about the nature of the tracheostomy, putting an artificial airway beneath the vocal cords, and you're just bypassing all of the, all of that anatomy that can become closed off, the tongue, the oral pharynx, any tissue around the false cords, anything along those lines. You're taking that pretty much out of the equation, but then you're dealing with all of the side effects of having a tracheostomy where you have now a humidity deficit, you have an opening for infection, not just into the airway, but around the stomas, you have all that care that needs to be taken. So, with all that said, it's just in the context of, the terminology and the treatment terminology, tracheostomy is in that arsenal, although reserved for a exceptionally small percentage of the individuals that have obstructive sleep apnea. So trying to tie things together here, taking a look at some of the take-home points. A friend of mine basically said, if you can go to a 1-hour lecture and walk away with, 2 or 3 or 4 things that, were valuable, then you probably accomplished something. And this is really just to kind of tie all of these various themes from this presentation into one kind of neat little package. So there's a lot of terminology specific to sleep medicine, specific to medicine, but also sleep medicine. And distinguishing between or amongst these terms can be potentially valuable. It also just, understanding the terms will also help you understand sleep medicine better. Terms can be categorized related to physiology, diagnostics, clinical consequences, and treatment. Some terms are similar, but may not be the same. And again, sometimes can be confused with one another. And therefore, understanding the terminology can help, if you will, distinguish amongst the terms, can also provide an enhanced understanding of sleep medicine in general and allow you to be more effective in helping diagnose and treat the patients that are so afflicted. So in this slide, I provided you with a variety of resources, and in the last few cases, some web resources that may be particularly helpful. So the Spriggs textbook at the top here, The Essentials of Polysomnography, 2021. For those of you who are respiratory therapists and have used Egan's Fundamentals of Respiratory Care, I'm one of the co-editors of this textbook. And Egan's, for those of you who, again, are not respiratory therapists, maybe nurses or sleep technologists, Egan's is the most widely used textbook in respiratory care by far, translated into something like 40 or 50 different languages. The point I'm making isn't really about Egan's, even though Egan's does have a chapter, very well done chapter on sleep medicine within it. It's to draw the distinction there. Spriggs is to sleep medicine. So Spriggs Essentials of Polysomnography is to sleep medicine, as Egan's is to respiratory care. I've also provided you with another one of my textbooks on clinical assessment and respiratory care. The 9th edition came out in 2021, and it also has a chapter strictly dedicated to sleep medicine, both in the mainly diagnostics, but also, you really can't discuss diagnostics without, touching in a significant way on treatment modalities. So it has a lot on that as well, and certainly has a lot of the terminology that we've discussed today is in Spriggs, Egan's, and in my clinical assessment and respiratory care textbook. There's also a respiratory disease textbook. It's a little bit long in the tooth. Came out in 2007, written by one of my colleagues, Bob Wilkins. But it also really does a great job of delving into not just sleep medicine, but also goes into some cases related to sleep medicine. Sakov's piece on obstructive sleep apnea and pulmonary hypertension really talks about it in the context of related disorders. And the last thing, AARC.org provide you with clinical practice guidelines related to sleep medicine and other white papers that can help guide your practice in both the diagnostics and treatment of obstructive sleep apnea. PubMed and Medline are the go-to that would give you a lot of these initial the resources, if you will, the studied papers based on the research studies that were actually done, and can be extremely useful in identifying what's called primary research resources. So with that, I want to thank you all for joining us today. I sincerely hope that you all got a lot out of this presentation. And most importantly, we really want you to consider having A&T Lectures be your go-to place for your respiratory care continuing education needs. Again, we thank you. We appreciate your joining us today, and we hope you have a wonderful day. Take care.